Right. I think we'll make a start. And I can see colleagues are joining on, so I'll admit them as soon as we we go through this. So good afternoon, everybody. Firstly, many thanks for taking the time out to join us for today's webinar session. My name is Karen. I'm the Partnership Officer for the Surrey Safeguarding Adults Board. And as part of my role, we're just engaging and developing ways in which we communicate with agencies across the county. And delivering our webinar series is just one of the many ways we'd like to engage with you to disseminate information and raise awareness around safeguarding issues and priorities. So today we are joined by Peter Rice from the Adult Social Care Mash Team. Peter has kindly offered his time today to give us some insights and learning around what to expect when adult social care receive a safeguarding concern and understanding some of the transformational changes within their team and how they've been implemented. We are recording today's session, so if you do miss anything Peter mentions, you'll be able to find the full recording on our website, and we will offer the opportunity for you to ask questions at the end. So without further ado, I'm going to hand over to Peter.
Thanks, Karen. As Karen's introduced me already, so Peter Rice, I'm the team manager for the Adult Social Care MASH, Multi-Agency Safeguarding Hub. I think just to provide some context, and many of you will be aware, but so that term is one of slight contention, moderate contention at the moment of a multi-agency safeguarding hub, because for a number of years we've been operating in a centralised but co-located model, so we're not an integrated team anymore. We have children single point of access sat in with us, police single point of access, Surrey and Borders. We've got 2 community psychiatric nurses, we've got public health sat with us, and some various other children's teams. So there is an awful lot of sort of safeguarding partner collaboration which goes on, but and from my point of view, we're more a partnership now rather than a multi-agency safeguarding hub from the traditional sense of what a MASH is. What I just wanted to check, I'll first come to Karen, just to check on the audience for today, in terms of how, from my point of view, how I conduct this presentation, and then after that, Karen, I'll go to everyone else just to check there will be space afterwards as well after the presentation. Any particular questions or queries people have got that they wanted to raise today of what to expect when making a referral to the adult safeguarding MASH.
Absolutely. So we've got a range of colleagues joining us today, Peter. From health, we've got adult social care, and we've got colleagues joining us from residential and supported living as well. So a mixed audience, especially from frontline staff to practitioners. So I think it's just an understanding of how we when we send a referral in, what to expect, in terms of feedback and any other learning from some of the referrals that have been submitted into the MASH team, and some of the new changes, I guess, that have been obviously ongoing within this year's changes within the transformational team. We have obviously got the cameras and mics off for colleagues, but we do have the chat bar open. Do you want me to open mics and cameras for colleagues now, or do you prefer it to be opened at the end?
Mics and cameras, that's fine to open now, Karen. Yeah, and thanks for that context. That's really helpful. That was a expected response, so that's helpful just to know that we've got a mixed audience today. And if people do want to pop in the chat as well, any questions that you've got, but it's just really just to check in before we get going if there's any particular things that people came along with today, expectations of queries that you would like to ask. I can see Karen's kindly opened the chat now, so you can either pop in the chat, or you can raise your hand, and then we'll take any queries now. Maybe a case that we hold those off till after, but if there are any queries, we'll just open for an opportunity for a moment. No? Okay, all right, that's good. Okay, I imagine there's probably going to be a range of queries that'll come up during. So again, do feel free to pop anything in the chat, and then afterwards as well, there'll be plenty of opportunity to raise your hand and come in and can discuss any queries that are generated. So I'm just going to start sharing our presentation for today. And Karen, can I just double check that you can see that?
We can indeed. Thank you, Peter.
Brilliant. Okay. So structure of this presentation, we'll be running through to discuss what is the adult MASH, what is an adult at risk, what makes a good safeguarding referral, how to make an adult safeguarding referral in Surrey. There's some recommended further reading and links at the end, but really those four key topics are what we're going to be covering today. And then, as said, there will be space then for questions and queries afterwards from anybody. So what is the Adult Multi-Agency Safeguarding Hub? So we're a central hub for safeguarding concerns relating to adults at risk. Anybody who is an adult where an incident has occurred in Surrey and there's concern that they meet the criteria for an adult at risk, they should be reported over to the adult MASH. And then what we do is we undertake inquiries with our partner agencies, perform checks of are they known to social care, gather information to decide what needs to happen from there. And we screen referrals relating to prevent referrals, so that's counter-terrorism. And then we also attend the once monthly prevent panel to share information, discuss planning for adults who are subject to prevent. We screen scarfs from PSPAR, which is a major part of our role of so we have our PSPAR colleagues sat in with us, so they'll send over wherever an officer's encountered somebody in Surrey where they're concerned about their vulnerabilities and safeguarding concern. That'll be sent over to the Adult Social Care MASH to screen and triage accordingly. We respond to children's mates. That's the... Oh, I can hear it. It sounds like someone's come off of. I can hear feedback. That's just me, Karen. I could hear myself.
No, I had some feedback as well. Colleagues, if we could just ask you to mute your microphones for now, and then towards the end, if you could open them up once you've got any questions for Peter, that would be really helpful. Thank you.
Sure, thanks, Karen. So we respond to children's MAPES. Just to explain what that is, it's a multi-agency partnership inquiry. So the children's sort of MASH team is now called the multi-agency partnership. So they'll send over requests for information, and then we follow their guidelines of timelines of response, which are identify if it's urgent or amber. Usually provide a response within 24 hours or urgently as soon as possible if it is something that's a urgent concern. Complete individual checks for partner safeguarding agencies where appropriate. So any requests that we receive from partner agencies of whether adults are known, that could be from people like probation, as far as things like the Office of Public Guardians, they will do checks there and respond to those. And again, we aim to do that within 24 hours where possible. We contribute to discussions and decisions about DVDS disclosures and also child sex offender disclosure scheme. So any information that we know about adults and in the context of care and support needs and safeguarding concerns. And then we liaise with our adult social care quality assurance colleagues and safeguarding advisors across the Adult Social Care Directorate. And that's something that we've always done, but it's becoming more of we're developing the strategic operation of that within the introduction of low-level quality concerns framework for community providers, which has been introduced from around about summer this year. We can come on to discuss that a bit later. I'm just going to pause there for any questions on this slide, because I appreciate that's a lot of different role and function of the MASH to go through, just in case there's any queries at this point. Karen, if you're able to note if there is any hands up or anything in the chat, typical presentation where it's difficult to see.
Yeah, absolutely. Can't see anything at the moment, so I think we're okay.
Sure. Okay, we'll move on. So to give an overview of how the Adult Social Care MASH is staffed, so we're a relatively small team in terms of resource for covering the whole of the county of Surrey and all safeguarding referrals coming in. So we've got one senior administration advisor, who we recruited into that position in around about April this year. They oversee all of the daily administration team functions, and they also support day-to-day with administration functions of the team as well. We've got 3 administration coordinators, which are a hybrid role between an administrator and a practitioner. They screen anything that's coming in to check, is it safeguarding concern? Is it known to a team? If it is known to a team, a case holding team, they'll send it over to that team to triage. Otherwise, everything else we will triage within the MASH and make a decision accordingly. We've got 4 social care assistants. So they effectively do what social workers do on an unqualified basis. So the expectations are less of them in terms of their expertise and knowledge, but they still take on screening and triage functions, and they take on casework function as well. And then our social workers, so that's our qualified workers, so they'll get allocation of safeguarding concerns, supporting the cover of our duty system, and then various other functions. And then we've got 1.5 senior social workers, same functions as social workers with the addition of senior functions to support the MASH senior team. And they do also take a lead in supporting with arranging our once monthly reflective practice framework and gaining speakers, and then also reflective practice in the team. We got 2 permanent assistant team managers. Currently we have none as of today, but we're recruiting into those. So they provide assurance checks and all decisions made in the MASH, support myself in overseeing day-to-day operations, provide ongoing supervision to our social workers, and then they review operations internally with partner agencies and are an essential part of the transformation work that's ongoing. And then myself, so the operational and strategic lead for the MASH, ensuring that we're practicing in accordance with legislation and collating information in Surrey, sort of keeping an eye on the data that we're getting from various agencies and our response to that in terms of quality assurance, safeguarding and commissioning. So partner working, our main agencies, as I mentioned earlier, that we sit in with. So we've got the police single point of access, children's single point of access, and then we got the 2 Surrey and Borders community psychiatric nurses. We link in with health services. Currently, we take a lead with the link with our acute hospitals, safeguarding leads for all safeguarding concerns that are received that have happened in a hospital. And then we link in with the community teams as well, Surrey Downs, and the other, I'm thinking of the other organisation, but the 2 major health bodies within Surrey for community health services. And then we also gather further information from various other partners. So this is a non-exhaustive list, but GP practices, Catalyst, and particularly we've got specialist cuckooing resource in Surrey. So we'll refer people who are subject to or at risk of cuckooing to them, district and borough councils, domestic abuse outreach services, Surrey Fire and Rescue, us all Tarina on the call, and then trading standards, so non-exhaustive list, but just an example of the sort of people that we're linking with to gather information to inform how we proceed with safeguarding adults. So some quantifiable statistics, again, just to give sort of a brief overview of what we receive into the MASH and deal with on a day-to-day basis. So as of the 1st of October, through the whole of October, we had 129 safeguarding concern contacts that were received and processed. So to say that's not everything that we receive within a month, but that stuff that we've received in it is progressing to a safeguarding concern. And then that figure below, so then in addition to that, we screened about 2,700 other contacts received and triaged. And then they've gone off on various different routes. So for example, it may be that we've seen that it's a request for an assessment rather than safeguarding. Typical example of that is low to moderate self-neglect that's received to us. And then also stuff we'll send on open untriaged if it's held by a case holding team for them to complete the triage. As of the 1st of October, so the latest figure I've got for today, we had 550 open cases within the MASH. Of those, we had 40 cases awaiting allocation. We're down to 3 today, so it varies day to day depending on sort of what we've received within the week. 175 cases in our health provider trays, and that's to do with the but 6 there. I think it's 5 acute hospital sites across Surrey, and then the 2 major community health providers. So Surrey Downs and Central Surrey Health is the one I forgot a moment ago. We had 199 cases assigned between the senior social care assistants and social workers that I mentioned, 7 staff, sorry, 8.5 staff, and then 20 cases in our medication error concerns trays as legacy concerns. So we don't have any of those cases anymore. That's now clear. And then 120 cases were allocated to MASH social workers for completion of safeguarding work. So what's that? The adult social care MASH is not. So gateway for reporting crime. We always advise this that the initial requirement is to make sure that it's reported to 101 for non-emergency or 999 in the case of an emergency. A way to request an assessment for someone who appears to have a need for care and support, where they need a care needs assessment. So it is still something we frequently see in cases of things like, say, self-neglect, where it's low to moderate self-neglect. The Safeguarding Adults Board policy sort of steers towards that. We will start from a position of providing assessment of need for that person. So that should be received over to the advice and information team. We are still, there's obviously cases of self-neglect where there are serious safeguarding concerns. So that's a judgment depending on the severity of the safeguarding concern, whether it's a referral for safeguarding or a referral for a needs assessment. Just something in bear to mind when making a referral. We have now our safeguarding portal has got some pre-screening questions which helps referrers to decide which pathway to take. Just a note on that as well, if it is received to us and we're thinking it needs a needs assessment, we will send that over to the appropriate team or information and advice. So it isn't the case that we'd be pinging that back. It's just, it obviously supports us as quick as possible to make sure it gets to the right place if that's considered. We're not a service for people in mental health crisis. So that is where police, if there's an immediate risk of concern towards life. Otherwise, we advise to contact GP or Surrey Borders Crisis Line for advice and guidance. So we do still receive a lot of concerns relating to people's mental health. Again, fine for us to receive, and we will do partner checks, but it's that key consideration again of if it's looking for support for somebody from a clinical sense for their mental health support, then the usual routes of GP, secondary health services, that's where we'd expect first. We're essentially about adult safeguarding concerns. So if there's a risk to that person of abuse or neglect, also neglect from others or serious risk of neglect, and that's the sort of things we want to be referred over to adult social care MASH. And then moving on to, following on from that, what is an adult at risk? So defined under section 42.1 as the 3-part test within the Care Act 2014. It has to be an adult who has needs for care and support, whether or not the authority are meeting those needs. So that means that they've got a condition, either health or mental health condition, that's impacting their ability to perform activities of daily living. And there are a number of specified outcomes, but you are guided again within the referral form. It does list what those are. I won't go through all of them now in the interest of time. They are experiencing or at risk of abuse or neglect, and then as a result of the care and support needs, they're unable to protect themselves from the abuse or neglect that they're experiencing or are at risk of. In order for the local authority to determine if a person is an adult at risk, we consider the information received in referral, speak with other partner agencies, and then review health and social care records, and speak with any other appropriate others, like informal people who may be involved in support, carers, family, friends, etc. And any information that we've got, but we can gather further information, we will. What makes good safeguarding referral? So all of the above that we've discussed, really, of just making sure of that critical point of making sure it is relevant for the purpose of adult safeguarding, that there's a concern that this person appears to be identifying as an adult at risk, and they're either experiencing or at risk of abuse or neglect. I've popped in here, which we'll share afterwards. For those who haven't seen, there is a levels of need document, which has been around for a number of years now, which we have in Surrey. It provides a really useful guide for referrers as well, in addition to the referral portal and the guidance that we've got there of the pathways of considering where to make your referral to, or if it requires a referral. And here we go. This is a display of it. I'd say you've got from levels 1 to 4, which is starting at universal services that can support to main needs that are identified. Then you're talking more prevention and targeted help, which is where it's identified that somebody's looking like they will need a full social care assessment. And then level 4 is to do with any safeguarding concerns that are identified. Things that'll come over to the MASH. And there's some further information there, which is the second page at the level of needs. It just expands a bit further to give some further guidance and example of what may fit within those categories. And again, at page 3, some further information of what may fit within those categories. And this is more for providers. So when is a safeguarding referral necessary? There's some guides here, and so green non-reportable. The thing that I'll note from this is really within the low-level concerns framework. If something if an incident has occurred and it's not a safeguarding concern, we would still expect that obviously the provider has taken action to address the concerns. They took an example with care homes that they've reviewed the person's care plan, taken any steps to address, say someone's got a pressure sore, care planning to address that. And then we expect them to have discussed it with the person, gain their views. If you're not able to do that, to discuss it with an independent representative. An example, if that person lacks capacity to be involved in their care planning. And then for community providers, we expect that is then reported to our adult social care quality assurance team. There's a separate proportionate form for that. And the reason we ask for that is really about themes and trends monitoring. If we're seeing a number of sort of low-level concerns, then that's the sort of thing where we'll review that and consider, do we need to send somebody in from the QA team to work with the provider to understand why that theme or trend is happening, or if there's any safeguarding concerns, so we can then plan of how we can address that and prevent any escalation where there's a theme or trend that's identified. Amber, requiring consultation. This is really where we're talking people are starting to fall within the categories of adult safeguarding. Should be recorded in line with internal organisational procedures, consultation with safeguarding lead, and then those are ones to consider, do they need to be referred over as an adult safeguarding concern? And then red, ones that are clearly reportable, that it's identified that it's likely the person will meet the criteria under section 42.1 as an adult at risk, and then that should be reported over to the local authority as an adult safeguarding concern. So here, as I've briefly referenced within the green non-reportable, we absolutely recognise that there's many instances where there is a concern for the person, but it's not falling with an adult safeguarding concern. So examples with our community providers, things every single day don't go according to plan. Just what we expect is that there is action taken to address when that does happen, and that duty of candor is being followed to inform the person or an appropriate advocate, and get their views and wishes, basically involve them within the process of what's being done to rectify the incident. Important, the information is included within the referral of small inquiry process. I'm just trying to interpret this bit. I think that's meant to be in there. Sorry, I'll move on to the next bit. If this information is not known at the time of referral, the initial inquiry response could be as simple as sharing the report as generated. Yeah, I mean, basically, what that's getting at is we still want information to be shared with us. It's just whether it's through the low-level quality assurance framework or if it's sent as an adult safeguarding concern, we still expect that information to be shared in some form. So information required for a safeguarding referral, so there's a list here, but again, the online referral portal, we've developed the form with the pre-screening questions. And the reason why we trying to make sure that all professional referrers, where possible, are using the referral portal is because it has been set up and developed in a bespoke manner off the back of what the previous safeguarding form was, and then updated with the absolutely essential information that we need to be able to screen and triage a referral once it hits our doorstep. And then also it's got the pre-screening questions there to support the referrer in consideration of the pathways that we've discussed, where there may be a concern, but it may be actually better followed up under a different route, and give some guidance there. So there's just a number of things there, but we won't go through all of those. It's just the sorts of things that we expect when somebody's making a referral over for adult safeguarding. So referral pitfalls, again, that really crucial point of not informing the person or a suitable representative about the referral and understanding what they'd like to happen. Obviously, there are the exceptional cases where there's a reason why it's not possible to do that. That's fine, just so long as that has been explored and explained within the referral. Where we get the pitfall is where something's sent to us and there's no explanation of why it hasn't been discussed with the person or suitable representative, or when that bit comes over blank and then we have to go back to the referrer before we can proceed. Not giving enough information about the concern itself, not detailing what actions have been taken to address any immediate protection concerns, not informing police where a crime is suspected to have been committed. So going back to the point we said earlier, if there's a crime, the initial point is inform the police, because they'll be the primary agency to follow up with investigation. It can come over as a safeguarding referral, where there's a vulnerable adult identified, but police will start with an investigation. Referral not being available to discuss concerns further where necessary. So when we've got a good referral, majority of the time, that's fine. We can screen, triage, follow up accordingly, feedback to a referrer of what's happening in response to the referral. But there are occasions, even with good referrals, that we may need further information. So really important to be available so we can gather that information, things like contact details, how we can get in contact with the person or the organisation to discuss any queries that we've got at the screen stage. So how to make a safeguarding referral. So since we've introduced the portal, that is really for professional referrals. We're asking where possible, please do refer via that route. There are other options though. So we've got telephone line in, people with communication difficulties. We've got text phone, SMS and VRS options. And then out of hours, it's reporting it to the emergency duty team. We cover all social care support within Surrey out of hours, so telephone numbers there. We do still receive a huge amount of contacts into our inbox on a day-to-day basis. Things for advice and queries were absolutely still open for people to send over queries to the Adult Social Care MASH inbox. We do also have, though, for general queries, we have our advice and information team who sort of field general queries in, so they're also contactable on that telephone number there, the 0300 200 1005, and they can provide advice and guidance. So what happens next? So we've introduced an update to our standard operating procedures from, I think it was around about March or April this year, which is now called the practice framework. And within that, we've put in the statutory guidelines for timelines of response. As many of you will know on the call, there has been an issue in Surrey with delay in response to referral, and then also something we're still continuing to work heavily on is making sure referrers have got feedback to referrals they've made at both the screening and triage point of what's happened in relation to that referral, and then ongoing if it progresses to a safeguarding concern, and feedback of what's happening during the course and then at the end of the concern as well. So we expect that within 24 to 48 hours, we've screened and made a decision and fed back to the referrer. Within 5 working days, if we're progressing on to a safeguarding concern, that Section 42 inquiry plan is created and shared accordingly with relevant people to respond to. And then within approximately about 4-week period max to have concluded an inquiry, unless there's any exceptional reasons as to why it extends beyond that time. And if an adult's already open to an adult social care team, we would refer it directly to that team. So making sure we're doing that as soon as it's received, so we don't cause delay. If referral is identified as not being a safeguarding concern, it's passed to the most appropriate team. So as we discussed earlier, we wouldn't send it back to the referrer. We would pass it on to either information and advice team, or otherwise, we're seeing clearly this is going to need follow-up for something like a Section 9 care and support needs assessment, we'd send it over to the relevant adult social care team. Safeguarding concerns held by adult social care MASH are assigned a priority rating, which dictates how quickly we respond. So a RAG system, we have a formal RAG guide, which we follow for continuity and consistency, both at the immediate stage of when something's received into us. Whoever the senior is on duty will RAG that immediately, and then onwards from there, depending what happens in outcome of screen and triage, we review the RAG. And then where there is any, if there is any waiting list for referral, we review every day and update RAGs where required. Social workers then review the information on our systems, request information from partners to make a Section 42 decision of whether further inquiries are needed. Non-complex inquiries relating to medication areas or acute hospitals, community provider, where the person's not known to a social care team, we complete these within the MASH. And then MASH provide guidance, information from and contact details for partners who need to be involved within the inquiry. So with professional referrers and partners, we would make sure details, information, contacts are being shared so that we can join up multi-agency working. And then will I receive feedback? So this is something we've been focusing on as a critical thing to address throughout this year is yes, we're committed to ensuring that every referral we receive, we're providing feedback. As I say, there's still ongoing work to do on that to make sure that people are getting the feedback at every single point. It would be appropriate for you to receive feedback about Section 42 inquiry if you have a role in the inquiry, where you've got an ongoing role for support with the adult, or if the adult has given their consent for anybody falling without those categories to have feedback. And then it is to say here as well, like if you are concerned that you haven't heard feedback, then again, our doors are always open. You can email into adult social care mash surreycc.gov.uk, and we'll look into that and provide feedback where there's any queries about what's going on with something that's being referred or an ongoing case. And I think that brings us to the end of the presentation. So I'm just going to stop sharing so I can see people again. It's always so unnerving when you can't see people in a call. Oh, I can see there's some things going on within the chat. Karen, did you want me to start reviewing through those? I don't know if you've been able to see things popping in now.
Yeah, absolutely. So I think the first one that we had was from Natasha, and she's asked, is it possible to clarify on the position with MASH and the note about this being for clients not known to adult social care? Recent reviews and advice have suggested we have to refer even when there is an allocated social worker, and this is causing tension and frustrations between agencies. So what is the right thing for them to do?
Yeah, sure. Natasha, if you want to come in here and give an example, I'm just going to have a look through that again because there are a number of
Hi,
parts.
Peter.
Hi.
Yeah, but basically, we have a number of services across the organisation that work with individuals with risk situations and have care and support needs on some levels. Some of those obviously have social workers in place, and we're working with those social workers. But obviously, when we're concerned that situations are escalating, or we're thinking it's moving more into sort of the safeguarding territory or requiring Section 42, maybe we are encouraged to submit referrals into MASH because that's come up in a review recently, and it came up in a review for a client where we contacted the social worker, but obviously the social worker either went off or was off for a while or something. But there was some feedback to us obviously around, well, you should have submitted your referrals through MASH, and we were sort of saying, well, we're working actively with a social worker. So I gave guidance to someone last week and said, look, we've had this guidance. Can you just pop it through on MASH? Make it clear that you're talking to the social worker, who the social worker is, all that kind of stuff, what you're doing. But obviously, understandably, that social worker was a bit like, well, why did you do that? Because I'm already in place, and I think my difficulty is if, and I think Karen, one of the reviews we're in at the moment, I think has got it as an action on we're discussing the recommendations. I think it's actually on the action plan. So it just would be really helpful for me as a safeguarding lead to be able to sort of guide my team when they come to me, because I feel that if there's a social working team already involved, then actually they're going to take that forward.
Yeah.
And MASH is for the unknown, but we have had advice saying that was wrong and we need to do it anyway. And so now we've gone the other way. So from your presentation, I would say, no, don't worry, continue to talk to the social worker. And if you don't get a response, go to duty. But, I just want that clarified in a space that I can sort of hold myself to.
Mm-hmm. Yeah, absolutely, Natasha. And so if it was referred over, if there's a new safeguarding concern, the important thing is to make sure that it is referred over. So if it's open to a team, I mean, what you're describing there is really linking in with the duty team, as you said, because people can be on non-working days, leave, sickness. And then to decide whether it goes over to them. If you made a safeguarding referral via the portal, it would come to us to reassure if it's open to a team. That's the things where we would then send it directly on to that team. So as well, I would advise that from the centralised position, if there's a new safeguarding concern, it's probably best to do the portal referral, because then it'll come through, we can screen it, and then we can send it straight on to the team, and we'd notify the worker as well.
Okay, I think that's interesting because sometimes the situations evolve, and I think that seems to be the sticking point, isn't it? Where nothing is that straightforward, but we're at the point where we're saying, well, hold on, this is really not going anywhere. The circumstances, we're trying to manage the risk isn't being managed, therefore it's more of a concern. And that's kind of when we get to that tipping point of, should we have done a MASH form now? Because these issues, yes, we're identifying them, but they're not improving, or these situations are getting worse. So I mean, okay.
Yeah.
So continue to submit something through the portal then.
Yeah, when
Okay.
if there's an ongoing safeguarding
Mm,
case where it's being looked into and that's open, then that's the sort of thing where I advise, talk with the duty team, talk with the worker. If it's something where it's sort of something that's evolving and hasn't got to the point of submitting a safeguarding concern, there's no open safeguarding case, that's the sort of thing where absolutely submit a safeguarding referral and they'll come to us. And we have got the additional step of there's partner agencies, etc. If we're seeing something,
mm,
we can cast a critical eye
mm.
on it in consideration of what might need to happen. But then as well, like it will come to us as the central team, so we can do that. And then if it's open to a team, then we can process and send it over to that team, and then they can follow up from there.
Okay.
So it'll be a centralised base.
We just got a little bit of short shrift, and I kind of understand it. But obviously, with adult social care, with the work that we're doing, it's not necessarily, we're there to try and reduce those risks before it gets to that space, isn't it? So
And
that's
absolutely.
generally
There's
where we
that
are.
sort
But
of
when
there is
we
still
ask the
thresholds.
question, has a Section 42 been considered, or does it meet the threshold, or is there any eligibility? It would be really nice if we got a response from social workers to explain the thinking, to say to us, actually, no, because of this, or yes, because of that, or yes, it's open. We had one open that never got allocated for months, and we were just carrying on doing the work, trying to keep him safe, and then it just disappeared. We don't know what happened to that one. So we've had a couple of experiences like that. So when we've had a couple like that, we've had some really good ones as well. But when it's like that, then obviously we do want a belt and braces to make sure the right people are looking at it from the right perspective, because it hasn't always gone smoothly, should we say.
Sure. Yeah,
All
I
right,
mean,
so
you're
we'll
talking
do
like
that. Okay.
chronicity there, aren't you? Something that's ongoing. So yeah, if you've tried the steps of, you're trying to engage your person and linking in with social workers and other partners, and the situation's still ongoing and you're concerned, those are the sorts of things, under the SSAB policy as well of 5.1,
Okay.
where we start considering of actually, is this falling into safeguarding territory
Okay.
where we're going to have to
Fine.
look at it under an adult safeguarding framework.
Okay. Thanks for that. I appreciate it. It's just obviously when I want to be able to say to the team with confidence, if someone pushes back, it's okay. I've had that conversation. This is the right thing to do. So thank you. Thanks
Absolutely.
for that clarification, Peter.
Thank you, Natasha. And Julie, I saw you had a couple of questions as well. So I'm not sure if you want to come in just to go through some of the queries you had for Peter.
Yeah, I'm happy to come in. Hi, Peter. It's Julie. How are
Julie.
you?
Yeah, not so bad yourself.
Yeah, good. Thank you. I think a couple of things that have come up recently is regarding when a person is not known to adult social care, whether they have come from out of county in, or they've moved from children's services and haven't transitioned over. It's about if they have a service already with SABP under the LD&A team, it's not always clear if adult social care are going to pick them up, because they said they don't know if they've got a learning disability, so they're asking for proof for that, knowing that they're under SABP already. So it's just, I think, just having clarification about would they automatically be in the right place to have a Section 9 assessment, or do we have to provide any documentation when the safeguarding is being raised?
Yeah, a really good question on learning disability. So I think the red herring here that sometimes can become problematic is within the consideration of that formal diagnosis. So I think what you're referring to, Julie, are learning disability and autism teams, just because the volume of what they have under their books. They do. There are one team in Surrey where they have a very clear criteria if they need that person to have evidence of a diagnosed learning disability, because those are the people that they'd be looking at providing support for. But that isn't to say that somebody who's got learning difficulties or autism don't have social care needs, they absolutely will be eligible for assessment and support if the specified needs are met in relation to their conditions. So, I mean, the guide I usually give to people is look at the care and support eligibility regulations of 2015. So it's a very forgivingly concise document. It specifies exactly what, the impact of whatever it is, a health or mental health condition, upon that person's ability to go about their day-to-day life within social care domains. If they're meeting any of those criteria, there's an appearance of need. And so that's something which can be referred over. And if they don't have a formal diagnosis of learning disability, but they do have something like learning difficulties or autism, then it would be the consideration of which other team. It wouldn't be the case that they're not eligible for support from social care. Is that they may not meet the strict criteria for the LG&A social care team, but they may then otherwise it would be a locality or mental health team, depending what the condition is, and the best teams take that forward. I hope that makes sense.
Yeah,
I'm trying to be as concise as possible, Julie.
No, and just the other quick one was, I know somebody else has put something similar in the chat around the low-level referrals. What we tend to hear is that low-level referrals have gone in several times, but and it's based on what the other lady was saying earlier. It's really just having some assurance that these low-level concerns are being recorded against the person's profile, just so that there is a holistic view if the issue is escalating, so that when it does go through again, you're aware that there's been other low-level concerns that have been addressed with quality, and it doesn't seem that low level and the MASH are, whether it's a recording issue, I don't know, but it just seems there's a little bit of problematic communication there, really. And I just want to clarify that the low levels are recorded against the person's notes, so that you do have that holistic view when we call back in again.
Yeah, I mean, it's a really good question, Julie. So, the low-level framework is still relatively new, ambitious new direction where we still want to capture everything. So, to give some context of what other local authorities will do is typically we'll put the onus back to the organisation to say, make sure you're taking actions, and then that's fine. We don't need to know if there's not an adult safeguarding concern. So the decision that we've made within the transformation this year is maybe differing to where other authorities have got a low-level framework in, is yes, we still want to know for the themes and trends tracking. So do still let us know, even if it's not meeting the safeguarding criteria. There is still some way to go, which we absolutely recognise within joining up the information received. So to give a brief explanation of how it works is our quality assurance team, anything that's received into them via the low-level quality form, it's then centralised onto I think it's an Excel spreadsheet that they've got, and then it will show the themes and trends that they've received in relation to providers, and then we link in with the quality assurance team frequently if we're seeing any escalation of concerns where we're seeing a provider coming through, or they're seeing it on their end. Then we tie together that information, and then that's where if we're seeing a theme or trend, then we'd meet and we'd decide what needs to happen to address that. And then we also link in with the safeguarding advisors for the particular area and service. So we've got safeguarding advisors.
Yeah, you mentioned care homes. So are the low levels currently just remaining with care homes, but individuals who live in their own home, or is that a separate process, or does the process, they're not in the low level process?
No, so the low level framework, it applies to any community providers that are regulated by adult social care. So care homes, nursing, and residential and nursing. supported living providers, and then your typical domiciliary care agencies. So if somebody's receiving a adult social care service within their own home, whether they're funded by Surrey or not, self-funded, if there's a concern that's received, then that's still information that we'd collate and identify if there's themes or trends or concerns.
But what about people
domiciliary
living in their own home?
Yeah, so domiciliary providers,
No,
we're talking.
yeah, okay.
Yeah, so when you say somebody living in their own home, so
Say with their family, and they're providing the care.
a family providing the care. So
Yeah.
if there was a concern, right, I mean, that falls outside of the low level framework,
Yeah,
generally, because
okay,
that's
that's
about
all I
community.
wanted to clarify,
Yeah,
because obviously
so,
that
yeah.
won't be. Yeah.
I
Okay,
mean, it's
thank
something
you.
that we term as family and private lives. So where somebody's got informal support from family, if it's received as a concern, then again, we'd be linking in with agencies, and we'd be looking into that incident within itself, with the person and others involved where appropriate. So, but it falls outside of the low-level framework. It's not about formal providers of care and support where we're reviewing for quality assurance and safeguarding.
Thank you, Peter.
Thanks, Peter.
Caroline, I think you had a couple of queries in the chat. Did you want to come in?
Yeah, I'll try and be quick. So I'm I suppose a social care assistant for Phyllis Tuckwell Hospice, headed up by a qualified social worker. Just wondering what the timescale is for a care needs assessment, because I think there's a common misconception that everyone who has care and support needs meets fast track CHC criteria. And for instance, we had a chap who slipped through the net, heart failure, COPD, following the normal trajectory of someone with those illnesses. And in the end, he was at risk of, he was self-neglecting, but also at high risk of financial abuse. And in the end, despite us flagging things, we brought him into the hospice where he died, because we just weren't getting any help from social care, I suppose. So just wondering the timescales.
Yeah, so it's typically about 4 weeks of time that the referral's made to adult social care assessment being completed. But obviously that's a guideline, Caroline. If there's a more urgent need, then again, similar to the RAG system, it is on a case-by-case basis. It sounds like a particularly complex example you describe in there, where you got these issues between, the interactions between social and healthcare. Really sorry to hear the outcome of that one. But yeah, so 4 weeks is a standard guide, sort of between 4 to 6 weeks from the time the referral was made.
And so in that case, when we had concerns, we were obviously leaving messages with the social work team. We had done it as a safeguarding concern. Should we submit another safeguarding concern just to make it a higher priority, or how do we flag it?
My advice would be, as general advice, Caroline, is start from the point of, if the referral's been made and it's ongoingly, it's being looked at under a assessment of need or safeguarding. If you've raised safeguarding, then link in with the people at ground level, so the social work team, social worker, health authorities. If though it's ongoing and you've got significant concerns and you feel that's not being resolved from the ongoing conversations and interactions with professional agencies, then again, that is something where you could refer it over again. Going back to that point earlier, the critical eye, if we're looking at something and there's something we can do to support sort of making sure that person at the service user, inverted commas, at the end of at the bottom of the referral process has got the relevant support in place.
Yeah, just obviously because a big part of that was ongoing financial abuse from a friend who wasn't really a friend. And my other quick question was, if we have a repeated concern with, for instance, a care agency or a nursing home, and we discuss it openly with the manager and we ask them to refer themselves because we believe it's a safeguarding concern, should we also do that too? And because we tend to do that at the moment, but also would we do it via the low-level referral portal?
Yeah, so you would do it as the send it over as low level portal. If it's a low level concern, if you're thinking it is something that falls within category of safeguarding concern, it comes back to the threshold document again.
Okay.
I mean, there is some caveat on that though, Caroline, because we're not expecting that every referrer is going to have access to the low-level threshold document.
Right.
So it comes back to that point of if you did send it over as an adult safeguarding concern, and then we review it and we think, you know, this is low-level threshold,
Yeah.
that's fine. We'd feed back to the person to ask, can you submit this as low-level concern, or we'd do it ourselves, and in either case, we'd then feed back to the referrer.
To us if we refer it. Yeah. Okay. Thank you very much. Very
Thank you,
interesting.
Caroline. Susan, did you want to come in?
I'll take my mic off. Hello. Hello, sorry, just a very quick question. I appreciate we're just coming to the end. Can I just have a quick answer to a very simple question? Is if somebody doesn't have any actual physical care and support needs, but they are a victim of domestic abuse, what are your thoughts on us referring that out? Because I've attended quite a few serious adult reviews around about domestic abuse, suicide, where it hasn't been referred out, but actually they didn't have any care and support needs. So just very quickly, I know it's probably you're thinking what a big question to end the session on, but just your thoughts on that really, Peter.
Yeah, that is a really good question, and you know, domestic abuse, as we know, is very sadly like on the rise and a serious concern for all agencies. So something I will say, Sue, for a general perspective. So PSPA have been doing a lot of work to modernise sort of information capture, and again looking at themes and trends. So they've developed a Power BI tool recently. And what it does is it basically looks for the history of concerns in any given case. So if the domestic abuse cases, for example, if police are aware of that and there's ongoing instances, then they'll be able to extract and see the risk. And if they're seeing that, you know, there's things like mental health concerns there or substance misuse or anything, then they can send that over and we can see at adult social care, and they put it as sort of synopsis now. It's been going on for about between 2 to 3 months, that it all informs that picture of if we're seeing that there's ongoing concerns of mental health, domestic abuse. So it does still come down when you're talking adult social care, of looking, are there conditions and impact on need here, but all the link in the stuff like our Southern Borders partners of things like, is that person receiving the right level of support for mental health needs? So I would say use your professional discretion to reassure you that police, you know, they will share information with us, and they follow the level of needs. And if they're seeing a theme, they cast a critical eye and they'll send something over if they're seeing there's a trend emerging there, and welfare concerns, they'll send it over. And then for us to consider, and we'll consider it again, that collaborative of agencies within the MASH. We can check with Southern Borders colleagues and other colleagues of what's being done to provide support to support a person out of that situation, or make sure they got support for any welfare needs that are identified.
Thank you, Peter.
Yeah, no, thank you. That's a lovely answer. Thank you very much.
Thank you, colleagues. I can't see any more questions in the chat, and I know we are approaching 1 o'clock now, so I think we'll close it there. Thank you, Peter, again. That was really insightful, and I think that was a great update in terms of what we can learn from what we receive when we send in a safeguarding concern to the MASH team. And I think in terms of the updates that's gone on with some of the transformations, I think it's been very helpful to kind of understand. So thank you. Colleagues, we have recorded the session, so it will be made available on the Safeguarding Board website, and we will upload the presentation as well. So you'll find everything on the website by hopefully the end of the week. And so thank you again for joining us today. We do have a couple sessions running next week. So if you have a look on the board's website again, you're able to book some of the slots on some of the sessions that we'll be hosting before the end of the year. So we hopefully we'll see you all very soon. Thank you.
Cheers. Thanks, Karen. Thanks, everyone. Bye for now.